Okay, our next question, another Ortho-k, lots of Ortho-k, which probably makes sense considering so many of us use the topography very specifically for myopia control, for Ortho-k analysis. I had a perfect candidate going into Ortho-k with -2 diopters, sphere in both eyes. As time has gone on, she has developed cylinder, plano -175, axis 180, with perfect topographies, meaning probably bullseye topographies. What do I do next? So we've induced this astigmatism. Why? And how do we fix it? Well, here is the topography that was sent in, and you can see it looks like a relatively straightforward case, mostly apical astigmatism, maybe arguably a little more limbus to limbus. It's a composite map, and that red vertical meridian seems to extend a fair ways across the eye. So that could be the culprit here. Looking at the post-wear map, you notice we're really not sphericalizing the central cornea. Notice these hot areas pushing toward the center. The astigmatism is really still there, and that's what Judy's describing. Our subtractive side shows us a blue treatment zone that's reasonably well centered, maybe a little bit low, but otherwise well centered, but we're not getting a great deal of effect across that steep axis. So when we look at the K readings, baseline, we're about 1 diopter of corneal astigmatism. Post-treatment, we've doubled the corneal sill. So it makes sense that the patient was manifesting so much astigmatism. 175, I think, was what was noticed or noted. So how do we address this? Well, one of the first things you gotta check is if you have an optimal landing 360 degrees around. If you've got a lot of fluid across one meridian, then, especially under the alignment zone is what I mean specifically, then the lens can be rocking back and forth. It can be decentering. We're not creating good hydraulic force. We're not trapping in that reservoir, this reservoir here, to create an optimal effect. So here you notice with the toric on this patient, same eye, we're able to create 360 degrees of alignment and trap that fluid layer in there, hopefully to create better effect. But maybe just as importantly, to create better centration, and maybe we'll benefit from getting better comfort as well. So check the alignment. If the fluorescein pattern shows a lens that really lacks good 360 degree alignment, if you're seeing a channel where the fluid is very obvious, where the depth of the lens needs to increase, we need more toricity, or it could be needing less toricity if we've overshot the toricity, but you have to figure out if we need to alter the alignment zone. So that's one of the things that we might check. All right, the next option is if it's not the alignment of the eye, if we really have the best lens to surface parameters and we're not pushing the sill out, what we could try is to increase the hydraulic force. So if we're using a base curve of, let's say, 4112 or 820 millimeters, and we want to increase the hydraulic force on the eye, try to push out the cylinder, then we might try a flatter base curve to cornea relationship. As you can see, as you go flatter and flatter, you're increasing the reservoir depth, you're increasing the hydraulic force. So that's one way that we might approach this. Since the patient isn't getting to +50 sphere, we're at plano, we could probably push a little bit more hydraulic force here, and hopefully by taking the patient to +50 along the flat meridian of the eye, we might get a little more hydraulic force across the steep meridian, maybe push out some of that sill. So increasing the effect is another alternative. When you're dealing with limbus to limbus astigmatism, and this patient appears to be toward the limbus to limbus side, it can be challenging to push that out of the way, and that's a limitation of orthokeratology. You can see on this patient we've got a nice apical astigmatism, very confined to the center. We can sphericalize most of the central cornea. Here, where you have limbus to limbus, the red and hotter contours running farther across the eye surface on the steep axis, and then that makes it tougher to push that out of the way. So this is one of those limiting factors of orthokeratology, and one that we have less control over. So it may be this is as good as it gets, but we'll try to check that alignment. We'll try to increase the hydraulic force, see if one of those two things or both can help with this case. So just to summarize this important question, because it comes up all the time, flatten base curve, improve the peripheral alignment, or another option that we haven't talked about is go to a truly toric back surface. So you have a toric landing to keep the lens on axis, but also toric base curves to create a toric hydraulic force. So you have one hydraulic force across the flat meridian, you have a completely different and stronger hydraulic force across the steep meridian. So this involves a fairly custom lens.